the opportunity to come and speak with you today. I'm really grateful to have this opportunity. This is the title of my talk, Exploring Strategies for Diversity and Inclusion, so moving toward health equity. And here are the objectives I set for us this morning. So I thought we should first still review the case for diversity and inclusion just to make sure we're really getting onto the same page here. I'm going to share with you a tale of what it might take to create change, and then we will explore strategies to promote diversity and inclusion, at least some that we've explored in our department. So I first want to recognize that, again, it's really a privilege to be here in your department because you are a department that is really intentionally already trying to work on these issues. So for those of you who are new residents, there is this report about your department's diversity, equity, inclusion initiatives from last year. And you'll find in here work that is already being done in your department about pathway efforts to promote diversity in health professional fields. You're doing already active faculty development in this arena. You're having outreach efforts, research initiatives, and then your department has produced a really long list of disparity publications and presentations. And I see that you're hosting the upcoming Women's Health and Health Equity Research Symposium in October, right? So that is all being done, but in the background, you know, Dr. McCabe Williams wrote this amazing piece in the Green Journal, if you haven't seen it, which really shows that even when you do all the right things, you've dotted your I's, you've crossed your T's, you get the rug kind of whipped out from under you. And this is happening to clinicians and your staff members, and certainly patients, you know, every day at this institution. So you can't, this is not kind of an arena where you can just check off the boxes and say you're done, right? This is work that needs to be continuous, and really, if we think about this on an individual level, this is really lifelong work to really look at issues around diversity and inclusion, such as bias, such as issues around microaggression, etc. So I thought, because it's very early morning for me, I thought I'd try to engage you all with a poll everywhere question. So I would like you to whip out your phones, and I want you to text 22333, and in the message, put in DFM 1100, and it should sort of welcome you to poll everywhere. So you got it? Okay. So because I'm not a member of your department, I wanted to ask you this question to get a sense of, you know, what you all think. So my question to you is, why do you think diversity is important? If you could try to answer that in, you know, 1 to 3 words, that would be great. Oh, great. I love it. Here at 7 in the morning, we can create this beautiful word cloud, right? So I just really appreciate how the ideas just flow here. So we're talking about patient care, perspective, we were talking about everyone. People think this is beautiful. Great, okay. So really lovely positive words to start our day, so I appreciate that. So I feel like, I could agree with all these words, so great. So I was just curious, did anyone in this audience have a chance to see Denise Rogers speak in January? So a few of you. So Dr. Denise Rogers is Vice Chancellor of Interprofessional Programs at Rutgers University and a powerhouse in leadership and family medicine. And I have had the enormous privilege of actually collaborating with Denise for the past few years about developing material to teach about racism in medicine. So we had the opportunity to invite Denise here to be our keynote speaker for our diversity summit at SMPH, which was held in January. And she gave this really compelling talk called The Inconvenient Truth about the impact of race, class, and gender on health outcomes. So this was a really riveting talk, but what I wanted to share with you was the quote that she ended another talk that I heard her give several years ago. This is probably, I think, the first time I ever heard Denise Rogers speak. And this is what she said. She concluded her talk by saying, it's all about the patient. And some of you wrote patient in the question that I asked you before as to why diversity is important. And so I just want to say to you that for me personally, this is what really clarifies why diversity, inclusion, and equity is important in what I do and perhaps what we do. I believe that probably all of us here in this room, whether you're clinicians, whether you're researchers, whether you're administrative staff supporting the OB-GYN department, fundamentally believe that we are ultimately trying to provide the best possible care and do research to attain the best possible care for all patients that we have an opportunity to care for. And to me, this actually brings a level of clarity that, for example, our colleagues at our campus in the English department and in, say, the French and Italian department don't have, right? So it's really, if we can hold patients in the center, which we don't always do, right? Sometimes we put the healthcare system in the center, we put patients on the outside. But if we can hold patients in the center, it becomes self-evident why diversity, equity, and inclusion is imperative. But this is the land we live in, right? So we live currently in a system where there are really astonishing health inequities, so really problems between the haves and the have-nots. And I don't know if any of you are familiar with this work, so this is Unequal Treatment. This is over 500 pages long. It was commissioned by Congress and published in 2002 by the Institute of Medicine. And after reviewing over 100 studies, they concluded that racial and ethnic minorities receive lower quality health care than non-minorities. And this is even when income, insurance status, and medical conditions are similar. And so we have been looking at disparities for decades. So Margaret Heckler actually started the Black and Minority Health Report as Health and Human Service Secretary actually under Ronald Reagan. And so we've been looking at this every year, and this is what we continue to look at to this day. So infant mortality rates are significantly higher for African American babies compared to whites. And this is particularly acute to us here as we sit here in Wisconsin, because we have the worst mortality rates between Black and whites and disparities. This is the largest gap in the United States of America. It actually is here in Wisconsin. And so I don't know, again, if any of you are familiar for the Race to Equity report. So, a few, okay. So this was published by what was then called the Wisconsin Council on Children and Families, and this is now called Kids Forward. So this was published in October of 2013. This was looking at disparities around social determinants, for example, issues around poverty, issues around incarceration rates, education, specifically here in Dane County. And this is the kind of data they came up with. So Black third graders were 4.5 times more likely to meet reading proficiency standards than whites. This was the worst gap in the United States of America. So we all think, oh, it's all in Milwaukee, or it's all in Chicago, right? But actually, at this time of this report, Dane County was harboring some of the worst disparities in the United States of America, in part because white children do so well in Dane County, but it's astonishing when you think about we are leaving behind whole groups of people by race. This came out in April of 2014. This was produced by the Annie E. Casey Foundation called The Race for Results. And this basically summarizes that perhaps the worst place for an African American child to grow up is in the state of Wisconsin. My brother was reading about this as a family physician in California. This was published in The Guardian in England. The other thing I'll just point out here is you can see here that actually, this is actually not a great state for Asian people to grow up in either. And I don't think they're talking about Asian people like myself. We are the third largest state with a Hmong population, and I think we're talking about our Hmong population here as well. from the Population Health Institute. This is our health report card. We actually don't do too bad as a health grade in general, but again, we are doing abysmally when it looks at the health disparity grade. And then I just wanted to point this out. This is a very interesting note on Dane County regarding poverty. So teenage birth rates for African Americans in Dane County are slightly lower than the rates for African American teens in the rest of our state and the nation. And then actually African American women in Dane County, so the percentage of African American mothers in Dane County who earn at least a high school diploma is actually higher than elsewhere in the state and the nation. And so usually this is protective. So if you have lower teen birth rates and higher maternal education, this should be protective from child poverty, but this is not the case in Dane County. So I'm just going to read to you some of the conclusions from the Race to Equity report. And I'm sorry, this is actually the slide that shows we are, again, the worst county or the worst place in the nation when it comes to childhood poverty and from a disparity standpoint. So this is what they say. The alarming truth is that our numbers taken as a whole suggest that the distance between whites and blacks in terms of well-being, status, and outcomes is as wide or wider in Dane County than in any jurisdiction, urban or rural, north or south, for which we have seen comparable statistics. The one inescapable and pivotal finding that arises from all the numbers we have collected is the extraordinary degree to which poverty and disadvantage in Dane County have been correlated with color, or to put it in even more stark terms, the extent to which economic deprivation has become profoundly racialized. Conscious racism and color prejudice may not have been the primary cause of this extreme racialization of disadvantage, but allowing such a close link between color and disadvantage to persist can only serve to nurture stereotypes, foster profiling, produce differential expectations for achievement within the community at large, while at the same time undermining motivation, aspiration, self-esteem, confidence, and hope among African American children and their families. So this is the county in which we are living right now. And then, you particularly, I feel like in the realm of OB-GYN and certainly in family medicine, there is increasing literature on something called the cumulative life course effects of social construct of race. Are you all familiar about this? Right. So when I started reading this literature, I was sort of wondering, aren't we just talking about racism, right? So we are finally using the word racism in medicine. I think we've been reluctant to do so. But a lot of the really core research being done in this area actually has been around infant mortality. And there's a really classic PBS series called Unnatural Causes. And I can certainly show you this video if you would like. So have anyone seen The Unnatural Causes, the Kim Anderson story? Does anyone want to see it? You want to see it? Okay. So it's about 5-6 minutes long.
Illustrates exactly what David and Collins are talking about. We know that a healthy lifestyle should lead to a healthy baby. Women who eat well, exercise, get prenatal care, avoid alcohol and drugs and cigarettes are more likely to have a good pregnancy. But one of the best predictors for a healthy pregnancy outcome is higher education.
This is a picture of me in May 1984 when I graduated from Columbia Law School. People think I'm living the American dream. A lawyer with 2 cars, 2.5 kids, the dog, the porch. A good husband, great family. I've always been lucky to have good health. Always ate well, exercised, never smoked.
So when we look at Kim Anderson, a well-paid lawyer in good health, we would expect her newborn to be a healthy, full-term baby. It didn't turn out that way. Back in 1990, when she was pregnant with her first child, Kim went into labor 2.5 months early.
I just wanted to know at least that if she was born alive, that at least we had a fighting chance. I heard her cry, thank God. But she was so small, I mean, you could hold her in palm of your hand.
Kim's baby Danielle weighed only 2 pounds 13 ounces when she was born. She joined the ranks of almost 300,000 low birth weight infants born in the U.S. that year. About 1 out of every 14 babies, all of them at a high risk of dying before their first birthday.
I remember getting home and being in the bathroom, I fell apart. You know, because it's like I didn't get to take my baby home, you know. I remember just sort of falling apart.
In the terminology of social scientists, Kim Anderson's family enjoys high socioeconomic status, which increases the odds for overall good health.
Persons who are higher in socioeconomic status, persons who have more income or more education or better jobs or more wealth, live longer and have fewer health problems than those who are lower in socioeconomic status.
Education, for example, predicts infant mortality for both Black women and white women. And the more educated you are, the less likely you are to have a low birth weight baby, a preterm baby, or an infant death.
Women who are poorest and least educated are those whose babies are at greatest risk in any racial group. But the babies of African American mothers with higher education are still at greater risk than we'd expect. Infant mortality among white American women with a college degree or higher is about 4 deaths per 1,000 births. But among African American women with the same level of education, infant mortality is about 10 per 1,000 births, almost 3 times higher. In fact, African American mothers with a college degree have worse birth outcomes than white mothers without a high school education.
Think about this. We're talking about African American doctors, lawyers, and business executives, and they still have a higher infant mortality rate than non-Hispanic white women who never went to high school in the first place.
As a mother, you're thinking, I did all the right things. They told me to take vitamins, I took vitamins. They told me to walk, they told me to eat vegetables, they told me not to drink, I didn't do all that. And why is my kid sitting there with these needles? And, you know, so you feel really helpless. You really feel helpless.
So Doctors Collins and David asked themselves if the answer could possibly be genetic. It's well known that prematurity can run in families. Is there something in the DNA of African American women that tends toward premature births regardless of education, prenatal care, or lifestyle? To answer the question, they created a study based on a simple assumption.
If there was such a thing as a prematurity gene and it came from Africa, then Africans should have more of it.
They compared newborns among 3 groups: African American women, African immigrants to the U.S., and U.S.-born white women.
It turns out that the Africans and the whites were about the same. The African Americans, on the other hand, had babies that weighed almost 8 or 9 ounces less than the other 2 groups.
In other words, African immigrants to the U.S. and white women born in the U.S. had similar pregnancy outcomes. So if there is any genetic predisposition for low birth weight babies, it's doubtful that it falls along what we call racial lines. It turns out that when African women immigrate to the U.S., it takes only 1 generation before their daughters are at risk of having premature babies at a significantly higher rate and with poor birth outcomes.
Has your heart rate been in that range over 180?
No, actually it's been about 160.
So within 1 generation, women with African descent are doing poorly. This to us really suggests that something is driving this. It's related to the social milieu that African American women live in throughout their entire life.
Okay, all right, so the cumulative effects of racism. you should all be aware of this report that just came out from the Foundation for Black Women's Wellness here in Dane County, released in February of this year. The Foundation for Black Women's Wellness is partnering with the Dane County Health Council and produced this report called Saving Our Babies. And they interviewed almost 300 African Americans throughout Dane County as we are all trying to collectively reduce disparities in low infant birth weights between African American and white women in our county. And what they found when they were interviewing people across our county were these sort of 10 themes that came up in their kind of qualitative analysis. And you can see the top one is racism, discrimination, and institutional bias. But if you look at the other 9 themes that came up, it's actually racism, discrimination, and institutional bias, right? They're actually all related to that at the top. So we're really dealing with institutional racism that we all need to think about in our work trying to reduce disparities in our county and participate in this work. And then I was just going to add, there's discussions around something called intersectionality. So intersectionality is when you start adding other complexities around identity. So it's one thing to be an African American, it's another thing to be an African American woman, it's another thing to be, let's say, a trans African American, right? So you add further levels of complexity, and then you oftentimes are heightening issues of, in this case, health outcome disparities as you do so. And then to sort of then really solidify, why do we need to attend to this? I mean, I think there's a clear moral argument for this, but there is certainly an economic for this if you start thinking about the demographics of our nation, right? So let me just ask you this. Can you just take a gander at what % of children in Madison Metropolitan School District are white? So just give me what % you think. So 80? 73, okay. Okay, great. Who said 40? Here's the prize winner. It's closest, and there we go. So it's actually longer prize. So it's actually currently 42% white for the 2018-2019 school year. When I moved here in 2010 from Washington State, this is kind of what I was told. You were moving to a white liberal town, and when I showed this to our department in 2014, I mean, my colleagues who've been living here for years, decades, if not all their whole lives, they had no idea that the demographics had really changed significantly over that decade in Madison Metropolitan School District. And in fact, in the year 2014, this is when the Department of Education in the United States said that public schools across our nation will be majority minority. That means majority people of color. So the whole word minority is starting really not to make sense anymore, right? So with that all in mind, I just wanted to share with you quickly some literature just to bring this into a little bit even sharper focus as to the argument for diversity and inclusion. So there are studies that show that diversity improves access to care for underserved patients. So underrepresented medicine physicians are more likely to practice in underserved communities and treat larger numbers of minority patients. And actually there's a study that shows that African Americans and Latinx as well as women are more likely to provide care to the poor and those on Medicaid. There are studies that diversity increases racial and ethnic minority patient choice as well as satisfaction. And there's actually a really interesting podcast, if any of you have like 35 minutes on a run or in the car or something that you like to listen to. This came out on NPR just about a month ago under Hidden Brain. It's called People Like Us, How Our Identities Shape Health and Educational Success. So really interesting around this very concept that when you have concordance between race and ethnicity, there seems to be improved outcome both in health and in education. Not that we really want to promote segregation, right? I mean, it gets to be a complicated argument, but you think about the landscape politically in which we're living in here in 2019, you can understand how people need safe havens today. And then there's an argument, as we're here at an academic institution, that diversity in educational environments improve the quality of education for health professionals, which in turn improves our ability to care for patients. So again, there's studies that show that if our, for example, residency class is more diverse, we will be able to have greater both empathy, greater capacity for cultural competence, or even maybe structural competence, so et cetera. So, and then of course in research, there's no question that diversity drives innovation. Diverse teams tend to study more understudied communities. They tend to promote trust when working with understudied communities. And there is a study that shows that racially diverse teams outperform non-diverse teams by 35%. Interestingly, only 7% of R01 grants from the NIH are awarded to African Americans or Latinx primary investigators. So the Institute of Medicine published In the Nation's Compelling Interest in 2004, which basically summarizes these points, that increasing racial and ethnic diversity amongst health professionals is important because it improves access to care for minority patients, provides greater patient choice and satisfaction, and improves educational experiences for health professional students. So I wanted to share with you what happened in my department in 2014. At the time, we were Public Department of Family Medicine. At the time, we had a huge HRSA grant exploring what it means to change the name of our department to the Department of Family Medicine and Community Health, which happened in 2016. So it actually all happened on March 21st, 2014. And do you know what day this is? Yes. This is match day of 2014. And what happens in my department, I don't know what happens in your department, we send out an email to our entire statewide department celebrating our incoming residency class with these photographs. So this came out on March 21st, 2014. And do you guys notice anything? Probably, because the talk I'm giving. Right? So I decided, I've been thinking about this issue for a while, and I decided to do something that I don't normally do. I decided to hit reply all, and I said something like, I don't doubt that these are all remarkable people, and these are all remarkable people. Let me tell you, these are all great family physicians who are practicing all over the country to this day. But do you realize it appears that we may have admitted a 100% white class. We are one of the largest and one of the most highly rated family medicine programs in the United States of America. And did you know that Madison Metropolitan School District at that time was 44% white? And so it was fascinating, the response I got after I sent that email. The few people of color in my department came up to me and said, oh yeah, it's the first thing I noticed, right? And then I have, lovely, remarkable colleagues who are white, who are in leadership positions, who, I consider very dear friends, who said to me, if you hadn't sent that email, I wouldn't have noticed, right? And so by that Sunday, my chair is calling me at home, and she said to me, this is in quotation marks, she said, you are now in charge. I'm looking at Dr. Rice, and I'm not sure if that's the best thing to say. So as I was saying, I was already having some discussions with some very dear colleagues. Some of you may know Dr. Ronnie Hayone, Dr. Patricia Tejas-Hiron, and actually Dr. Nancy Pondy, who is now at the University of New Mexico. We were already having conversations about this issue before, but this match day came out. And so it was Dr. Nancy Pondy, who was one of our tenure track faculty, said, oh no, you cannot be in charge without some support from leadership, okay? So she had the wherewithal to give me that mentoring advice, And so actually, because we were literally at the time exploring this question of becoming the Department of Young Medicine and Community Health, we took some money out of our huge HRSA grant and we applied it to what we then developed as the 2020 initiative. And I got a little bit of FTE to lead this effort and be in charge, and then a small grant to do this. And this is what we did in 2014. So we started by first increasing awareness of diversity issues within our department, community, patient populations, and department. This is actually where we were presented the race to equity report. And I was like waiting for faculty to talk about this really. I was, oh, I'm the one who's supposed to talk about this, right? So this is what we started with. And this is also what we did at the beginning. We sort of surveyed our department. So are you committed to addressing issues posed by challenges of diversity in healthcare? Of course we're interested, right? There's that. And then, are you examining local data on health or healthcare disparities? And then the answer is, well, actually, we rarely kind of look at that kind of data, right? So we claim we're interested, but we weren't really intentionally doing anything in our department around this. The next thing we did was we spent several workshops. Again, this we kind of beamed out to our entire statewide department, trying to identify and prioritize potential interventions that can increase department responsiveness to diversity issues. So we were looking at best practices. So we studied this article from the Robert Wood Johnson Foundation, which basically was trying to provide a roadmap to help us move toward health equity. Basically, one of the most critical things you do at the get-go is you have to equate quality with health equity. It's synonymous, right? So that's an example of what we were looking at there. And then we were looking at best practices not only in equity but in diversity. And then we found this amazing article that comes out of the Medical University of South Carolina. It's a slightly frightening article, but it's amazing what they did over a 10-year period. But what's a little bit frightening about it is it's not just the chair who is mandating change. It was actually the chancellor of the university who mandated all her chairs to do this. But it was really remarkable what they did in 10 years because the chancellor said, South Carolina is 40% African American. We cannot look like this as our state academic institution. And then finally, we applied some of the funding we had to bring in some professional facilitators. And now that we felt like authentically engaged our department in some of these issues, we then led a brainstorming session to help us try to start developing a strategy to assure a commitment to health equity, diversity, inclusion. And we actually ended the session by everyone folded paper cranes. And so there's actually a collage of our paper cranes in our department now. So strategies to consider. So I was just going to share with you quickly, what have we done then since 2014? So one of the things that came out was that, again, people felt that we needed to keep attending to this. We can't just have one session and then we're done, right? So we actually formed a Diversity, Equity, and Inclusion Committee, and so this was our charter. And we are continuing to meet to this day and have done a lot of really interesting work that actually people are looking at around the nation. And we have really broad representation from our clinical side, our educational side, our research side, but we also have the wherewithal to include someone from UW Health as well as SMPH so that we are in alignment with our other larger organizations that we collaborate with, which has been great. And I was totally raring to go on all these projects, and my wonderful committee, as we first formed, said, no, we are not doing a thing until we create a mission, vision, and value statement. We spent several months working on this. We, again, had a professional facilitator work with our committee who was so moved with what we were trying to do. He came from the Office of Strategic Planning, that he kind of worked with us for free, actually, to develop this. So I had already developed something called the mnemonic of trust. So we were looking, and this turned into our vision statement. So we've been looking at issues of tracking, recruiting. The U is unlearning and learning. S is sustaining and retaining, and T is training and transformation. And our mission became our department's Diversity and Inclusion Committee exists to promote health equity, diversity, and inclusion, to advise on processes related to recruitment and retention of diverse learners, faculty, and staff. And I'm just going to quickly share with you kind of our values or beliefs that we wrote. Because when I came back and looked at this, I thought, oh, that's really great what we've been doing. So we believe that social identities such as race, ethnicity, gender, and others are social constructs embedded within a context of unequal power relationships that allow privileged groups to benefit at the expense of marginalized groups. Okay? We believe that equity assures justice and fairness for all by addressing systemic biases in policies and practices, and assures that health equity drives the culture and actions of the department. We believe that inclusive practices assure that dominant and privileged voices are decentralized to create full and equal participation and access for all groups. And we believe that bringing a healing attention first to our own privileges and unconscious biases allows us to mindfully engage in equity inclusion work while serving as equity inclusion leaders for the department. So where did we start our work? So although the mnemonic reads like this, we actually started under S, and we started under the sustaining and retaining. So we believe that although diversity is actually the more sexy topic, it's actually far more important to focus on issues of inclusivity. So we actually started there. So there's an article out of the Harvard Business Review about diversity doesn't stick without inclusion. And so one of the things that we thought would be a really beautiful project to start with is around mentorship. So fortunately, here at the University of Wisconsin, we have some of the leading mentorship experts in the nation, if not the world, in our backyard. So we collaborated with people like Angela Byers-Winston. We got input from Chris Fund, who work with places such as the National Research Mentoring Network. These programs, and you can find this through ICTR, are primarily about mentorship for our research tenure track faculty. But for our Diversity, Equity, and Inclusion Committee, we believe that mentorship can happen at any level. So we were even interested in mentorship across staff to staff, let alone within our clinician or physician community. And we believe that mentorship can be bidirectional, that mentors can be as enriched by mentees as mentees by their mentors, right? Especially when you are bridging difference, right? And so we kind of riffed off the NRMN's toolkit and created our own mentorship toolkit that has a really deep lens around equity and inclusion work. So there's a lot of resources in here around mentoring across difference. So tracking is clearly important. So then we started to try to develop a diversity dashboard. So we were thinking that we should be looking at leadership diversity metrics. This is still a work in progress. But it'd be interesting to know if we actually looked at every year, like by maybe gender, race, and ethnicity, who makes up our leadership teams. We certainly are looking at issues of recruitment of faculty and residents and retention. And then we were doing a lot of curricular development, both for faculty development as well as our residency. So we kind of transformed our residency curriculum and now do a lot of teaching around what I'm going to call structural competency, not just cultural competency. And then we were also have been trying to seek opportunities to provide transformational learning opportunities. So we're trying to think that we should be tracking all these things. So similarly, you have your diversity initiative report coming out of your department. So sort of similar to that. This is an example of what we have been able to track for our residency. Now I realize that we have a very unique GMAC that is separate from the rest of SMPH. So we were able to disaggregate data by race and ethnicity very early in the process. And by doing this, we were actually able to start looking at not only who do we finally accept, but where might we be preferentially biasing things when it comes to interviewing? Like who do we interview, right? Who do we not interview? So we actually started to look at all these different aspects. So last year we found out that we actually were preferentially biased toward interviewing white applicants. And so we have continued to revise our residency recruitment process. So I'll get to that. This is actually data about, but we're talking about metrics right now. So these are metrics around faculty data that I was able to pull up for your department. And this is 2018 data, so this is hot off the press. They gave this to me on Friday. So this is an example of the kind of data you can get out of HR at SMPH. So you can sort of see that there's a rising number of women, in this case, who are assistant professors. And fortunately for full professors, women are continuing to increase, but there's still more men than women. And then you can also look at this for race and ethnicity. And unfortunately, there's a glitch in the program. So the color codes are different in each chart, which is a little annoying. But basically, it's white people on the top, expect, and all the people of color are on the bottom. It's always astonishing to actually see this. Like, we kind of know this inherently, but I think it's important when we think about a diversity dashboard to actually have a leadership team actually look at it. You know, could you please just look at this once a year and just make some acknowledgement of that? Because you're not going to really create change if you're not paying attention. So this is one potential arena to promote accountability. So then when you start doing tracking, then you start to change things around recruiting. So I just wanted to give you an example of what we've done in our residency. So we have changed how we review processes for even interview invitations. So we are no longer automatically inviting people based on their board scores. We're now blinding people to grades, test scores, and applicant photos. There actually is no data that shows the higher your board score, the better you're going to be as a physician, right? There's probably a single cutoff that you should probably attain, but there's really, you can't say just because your board score was 20 points higher than the person sitting next to you that it's going to make any difference. We've blinded interviewers to grades and scores, and we're using the AAMC's experiences, attributes, and metrics model, which I'll show you, for reviewing final applicant selection. And we had made some changes the year before. We were using more standardized interviews, questions, which is a great idea. And we're now attending the Student National Medical Association Conference, which is the largest African-American student medical organization in the country. All of our members on the Residency Recruitment Committee review this video, and we talk about issues of unconscious bias. And this is that AAMC experiences, attributes, and metrics model that we are using as we do our final review of candidates. The other thing I want you all to know is if you would please enter this website. The USMLE is asking for public opinion because they are actually actively exploring, as we speak, whether or not they should change the way they are doing score reporting. And you have one more day to provide input. It's open until July 26th, I believe. And so they have a lot of literature in there that you can review, but you can actually provide a response as to whether or not think this group should continue to promote change in this arena. But they're really looking at whether USMLE should be more of a pass-fail. So then other things that have been happening in terms of recruitment on the actually potentially faculty and staff realm. I've been working with the folks in the Office of Diversity at UW Health. So Naomi Takahashi and Shivar Beater-Salif, who are our Chief Diversity Officers, created this wonderful checklist around reducing bias in hiring. So I can't get to every single clinic across my humongous department. So we provided them this checklist. And then I hope many of you who are involved in faculty recruitment are aware of the Wisely Center's wonderful workshop, Searching for Excellence in Diversity. Molly Carnes is one of the leading experts in the world about issues of implicit bias, particularly around gender. And just FYI, their next workshop here at Health Sciences is October 22nd. Unlearning and learning. So this is, again, an area that I've been doing a lot of work in terms of creating new curriculum. And most recently, I was part of a large national strategic planning group for family medicine, and I was part of the health equity team for Family Medicine for America's Health. We actually hosted a huge national conference in Portland, Oregon, bringing in thought leaders in health equity from around the world. And we ended up being able to capture all that. And so I led development of something called the Health Equity Curricular Toolkit, which you are all most welcome to use. So I've given you the website link if you're interested in that. But that's sort of an example of the work that we're actively involved in. Within this toolkit, there's a section that's really devoted to trying to move us to an actionable phase in our work toward health equity, which includes really applying an equity lens to our work. Do you guys know what I'm talking about when I say that? So I became quite enamored by this sort of checklist, really, that comes out of Multnomah County. So this is where Portland, Oregon is. And it's really an opportunity that when we have a chance to intervene for anything, let's say quality improvement work or formal research for that matter, we should be applying an equity lens because we sometimes, I think, forget about, oftentimes because we're not a very diverse team, right? That we are sort of leaving people behind in the work we're doing. So these are just literally prompts that sort of say who is advantaged and who is disadvantaged by this proposal that you're making, right? Where are there potential opportunities where harm might be caused? Are you including patient voice as you're doing this intervention that affects, patients, for example? So that's kind of in the toolkit. And finally, training and transformation. Some of the work we did in our department was we decided to have Groundwork, which is a local group here made up of predominantly white people who are really trying to work on active anti-racism work. And they came and led a statewide departmental lunchtime series for us, which is all captured on our website. And then finally, UW Health has created these microlearning modules, which is another area that our department is going to pilot this in several different units to see, is this another way that we can have active engagement at our monthly meetings for things by going through some of these microlearning modules together as a team. And fundamentally, almost really all the research that I have done over the years is really inspired by this quote from Anais Nin, famous early 20th century feminist, who said, "We don't see things as they are, we see things as we are," right? So it's kind of like we are holding the camera, and we can make people look more or less flattering the way we hold our camera, right? So I feel like a lot of the work I try to do is kind of keep holding the mirror up to ourselves and saying, before we go out to go help all those people, how are we complicit in this and what sort of self-examination should we be doing? So a lot of the teaching I do involves looking at issues of implicit bias. So there's something called the Project Implicit, where some of you may have done this, you can explore this yourselves on your own time. And then finally, as we all start to do more real intentional work internally, I'm hoping, I think then there comes a point that we may become ready to start looking at what we look like externally to other people. And so this is currently your web page, and I want you to know this is what we put on our public-facing web page. This took years to get that tab put on. And this is an example of allyship by a white man. So Bill Schwab, who's in the middle of that picture, is my practice partner. He's our vice chair of education and a very dear and wonderful man. And he finally said to the executive team, which he sits on, he said, the AAMC, I was at a conference, and they said, if you put diversity on your public-facing web page, that makes a really big difference when it comes to recruitment of residents and new faculty. So this actually was only just done, I think, last October, even though we talked about this years ago. And so if you go to that site, I just want you to know a lot of what I'm talking about today is actually housed there. So for example, our mentorship toolkit is yours, so you're welcome to have access to that as you look at that. And then finally, I just wanted to say really quickly, Bryan Gittins, our former Associate Dean of Equity and Diversity, who has sadly left us, he started something at the School of Medicine and Public Health called the Diversity and Inclusion Advocates Program. So I am now sort of directing this and have the input of a lot of other wonderful leaders across campus, such as Wisely, Vice Chancellor of Workforce Equity and Diversity. And so we've been training some core members of faculty administrators from around SMPH to sort of act as mini chief diversity officers for everyone. And so we're really looking at being experts around helping provide resources to departments as needed. And we're really primarily focusing on diversifying faculty recruitment. And then secondarily, we of course want to diversify the whole system. And I'll just share, so we have great aspirations. And then currently, these are all of our current diversity inclusion advocates. And Parvati Pillai is actually, although she's with preventive medicine, is assigned here to OB-GYN. We'll be sort of announcing a second cohort of DIAs, so there'll be opportunity to have someone from within OB-GYN as well, if you're interested, probably in spring as we have a new dean. So I'm just going to stop there. I realize I haven't left you a lot of time, but wanted to bring up Melody Bachenfeld, as already there's some interest in starting some ideas here, and we might have a little bit of time to do a little bit of brainstorming.
Thank you so much, Dr. Edgoose. Just very quickly, I'm Melody Bachenfeld. For those of you I haven't met, I am the Outreach Program Manager here at the department, and Dr. Okay. So just very excited to announce that based on the great example that Department of Family Medicine has set, they are serving kind of as a resource for us to help us get started in forming our own Diversity, Equity, Inclusion Committee. And Dr. Rice has asked me to kind of help organize this, so I'm really excited to kind of serve as a staff champion for this. And DFM has shared their committee charter, so we have a really good working document to start with. So kind of open recruitment right now, looking for faculty, staff, trainees, anyone interested in working on the Diversity, Equity, Inclusion Committee, kind of determining the course for the directions that we want to take. There are, as Dr. Edgoose mentioned, there are so many resources out there to help us get started. This is something I talked to Dr. Rice about. I'm involved with the Wisconsin Public Health Association Racial Equity Work Group, and we've put together a declaration that racism is a public health crisis with a whole set of actions that organizations can take. This is just an example that we could use to help us kind of chart our direction. And I also just want to mention that thanks to Jackie Askins and our great IT team, we've already put together a shell of a Diversity, Equity, Inclusion web page for our website, and most of the references that Dr. Edgoose shared today are already on there and linked. So we're already kind of off to a good start. There are also many other great resources in our grant round section that we'll be pulling together. So we're just getting started on that, and really wanting to get input from everyone about how they'd like that to look. So I don't know if we have time left over, but these are the questions that we're going to be asking you, maybe in a survey, to start to get feedback from the department about what directions that we should take. So thank you.
Thank you. Should we give her a round of applause?